start today, what I'd like to do is we're going to bring together the concepts of minimally disruptive medicine, shared decision making, and ICANN to start to understand what it would look like to fit care and the voice of our patients into our practice. This works.
There you go, click. Now click again.
Thank you. Being a little temperamental with me. So, in order to understand what it means to fit care and the voice of our patients into our practice, we first need to understand our current state and why the system is broken. And then we'll review the concepts of minimally disruptive medicine, shared decision making, and how this applies to fitting care and the voice of our patients into.
There's some mic issue. It is on.
Am I just not close enough? Am I not loud enough?
You're not loud.
Use your Casey voice.
Darn it. There's a Casey voice here. Okay, I'll speak louder. So we'd like to also then look at, so as I shared, review the concepts of minimally disruptive medicine and shared decision making, and how this applies to fitting care and the voice of our patients into everything we do, and how to utilize the ICANN discussion aid to facilitate conversations and the opportunities that exist within each of our practices to change the way we deliver care to our patients. You all may have noticed that I titled the talk Value. And I wanted to start first to provide the definitions for value according to Webster's Dictionary and Google. Again, value as a noun is the regard that something is held to deserve, the importance, worth, or usefulness of something. When it's utilized as a verb, consider someone or something to be important or beneficial, to have a high opinion of. I share this because I want all of you to reflect on the following during the talk. What is meant by value in healthcare? How and by whom should value in health and healthcare be defined? Should it be defined by healthcare institutions, by insurance companies, by clinicians, by patients? Many of you may be wondering, is there a problem? Why should this matter to me? And in American medicine, don't we provide high-value care and have excellent outcomes? Don't our patients trust us? When you look at this survey, it appears potentially not. So this was data that was collected for patients that were leaving academic hospitals or outpatient visits. It was first recorded in 2005 and then repeated in 2009 without significant change. Less than half of the patients, when they left the outpatient visit or left the academic hospital, could state what they were even there for in the first place. Less than half of the patients. A third of the patients could state what medication they were on and why they were taking the medication. Only a third. I think many of my colleagues, when they look at this study or look at this information, they tend to focus on the very bottom, the 50% of prescriptions that went unfilled and the 50% of medications that were taken improperly. I think that's actually quite impressive, given the fact that people had no idea why they were in the hospital or why they were in the clinic in the first place. So, the 50% of prescriptions that went unfilled has actually been, unfortunately, a repeated statistic that's been shown in many national studies. And what this shows that is in healthcare, we are doing a great job at doing things to people, but we aren't making a connection with them. And we've been adding to the workload of being a patient without being able to understand what it means to be a patient and understanding what that burden of treatment looks like for our patients. Another set of data that we've collected that helps to illustrate this is from work that we've done with colleagues at the Center for Innovation. When we met with patients and asked them to share with us some of the top reasons why they have barriers to engaging with healthcare, these were the top 4 reasons that were cited. Cost for patients and that they felt too busy both elicited that the value in healthcare has been something that we've struggled to show patients exists. For patients, when they shared that insurance was a barrier to them, It was often because they had no idea what their insurance plan was. They struggled to know who was in network, who was out of network, and what their out-of-pocket costs would be. And then for the patients that said, I'm not sure what to do, those patients said that when they needed to engage with healthcare, they weren't sure who to reach out to, where to go, and how to even navigate the system. This all demonstrates that in healthcare, there's a significant lack of transparency. And I want to bring the discussion back to some of the concepts that we all heard earlier today around minimally disruptive medicine. And I think the best way to illustrate it is to share a story. I know all of you heard about Sarah, who's one of my patients. Again, change the name to the patient, so not truly the patient's name, but I'd like to share one of my patients, and her name is Karen. She is a 55-year-old woman who I had assumed care for when I started out in practice. She had been diagnosed with type 2 diabetes many years before I met her, and she had been tried on several medications in the past to manage her diabetes. When I met her, she was taking 2 medications to manage her diabetes. She also had high blood pressure and was on 2 medications for her high blood pressure. And then she'd been found to have high cholesterol, so she'd been started on a statin medication. And over the first few years of seeing her, she would come in for some visits, she would not come in for other visits, and then when it came to lab tests, sometimes she'd be able to make it to the lab tests, other times she would not. And the times that Karen would come into her visits with me, her and I would engage in our typical back and forth. I would notice that her A1C was worse. I'd come in to see her, and she would share with me all the things that she knew that she could and should do to change her diet, to change her activity, that she would hope would improve her A1C and her diabetes management. And then I would take my approach at trying to convince her about the severity of her diabetes, and that if we don't change it, all the complications and the risks that were in her future, and try to make sure that she really understood how important this was. Then I would suggest to her that we either increase one of her medications or we add another medication. She would initially resist, and then she would agree, and our cycle would start all over again the next time I would see her. And unfortunately, I'm embarrassed to say that it took many years and too many years for me to realize that what I had been trained to understand and to recognize for Karen was that I was trained to see her as a non-compliant or as a non-engaged patient in her care. And what I had neglected to understand or to recognize was the burden that she was experiencing from her multiple chronic conditions, or where she was identifying value in the care that I was providing for her. So I just continued to repeat my cycle over and over at first. So what role do I play as the primary care clinician in her workload or in her burden to her treatment and illness? This was a survey that was sent to primary care clinicians via the Mayo. And the 627 primary care clinicians that were surveyed, they felt that 50% of their patients were receiving too much care. And that 50% of primary care clinicians were too aggressive with the care that they provided. In this survey as well, 45% of the clinicians said that in a typical workday when they saw patients, at least 1 out of 10 patients that they saw could have been managed in a manner different than a typical visit. So they could have been cared for through a telephone call, through an email or portal messaging, or with a non-physician staff member such as a nurse. And so if my colleagues, so primary care clinicians, feel like we're too aggressive with care, what do patients think? And what we've discovered in the work that we've tried to do to understand what health and healthcare means for our patients, here's what we've learned from people, is people define health not as the absence of disease, but as their ability to function in their daily lives. Meaning, they don't necessarily care about their A1C value, but they care about their ability to go to work every day. If you compare this with research that has shown that healthcare, focusing on ridding people of disease, is responsible for only 10% of the healthcare gains in the last century, compared with the social determinants of health, such as housing, education, employment, and nutrition being responsible for 90% of the healthcare gains, it tells you something. So for Karen, although her A1C was really important in practice to me because her A1C was something I was going to be measured on, and it was part of our healthcare measures and outcomes, to her, it was just a number, and it was added work that I was putting on her. And related to this insight is that people have a reason for everything they do. And if a patient chooses not to follow our treatment plan or the regimen we've outlined, they've got a reason for it. And often it's because they'd like to go to work every day and focus on that versus being a professional patient. Patients see themselves as, in part, consumers of a service. And they believe and should that they each have unique values and beliefs, and they want these to be considered when we're making decisions regarding their health and the care they receive. With this in mind, we see that populations will begin to look for services that will support their health, rather than services that will continue to do things to them in a futile attempt to just rid them of disease. The challenge, though, in our current system is that how we practice and how we provide care is with evidence-based guidelines that are disease-specific. And what we think is best, or what we suggest is best, it's often going to look like a target, or it's going to look like a guideline or a selection of tablets that we're trying to offer a patient. But in those cases, we often don't know what our patients think. And when you start to look at healthcare from the perspective of patients, you see how it's really been designed around the needs of the system and not around the vulnerable patient that's sitting in front of you. So you take, for example, here, this is one of the exam rooms actually in one of our clinics. And the vulnerable patient sitting in his exam room is staring at those stirrups, thinking, do I need to take my clothes off? And that patient's going to sit there thinking that until somebody says, don't worry, you don't need to take your pants off. Or the diabetic patient that's sitting in this room, that patient's going to sit there thinking, gosh, I don't know why my A1C is worse. I really hope they don't yell at me about it. And that patient's going to continue thinking that until somebody says, it's okay, I've seen your A1C and we're going to figure this out together. The bottom line is, how can people trust a system that seems to value their experience so little? And this brings us to another insight in work that we've done, which says that we don't really know where we're creating value in the clinician and patient relationship. And that's because the healthcare system wasn't really designed around the needs of its ultimate customer, the patient. Our healthcare system was just kind of happened, and it's been built around this very bizarre payment system. And we're really in the business of doing things to people, and we're really good at it. And if you think about it, the system overtly rewards us for the things that we do to patients. We're all good people with good intentions, yet we're trapped in a system that doesn't support us or our patients in understanding their unspoken needs. And this gets in the way of understanding what the patient really needs from us. Which leads to our next assumption, or excuse me, our next insight, and is that we can't make assumptions about what patients need without talking to them. Although we often tend to make assumptions about what patients need based on their clinical status, and if you think about it, we're often really good at it. So we often will base patients based off of how many medications they take, how many ER visits they've had, how many chronic conditions they've had, and then it leads us to the clinical stratification pyramid, where the top 10% are the really complex patients who've got multiple chronic conditions, and then at the bottom of the pyramid are the patients that we assume are otherwise healthy and assume don't really need anything from us. And so those really complex patients, we say, gosh, they're really complex, they need a lot of help, so we create all these high-touch interventions such as multiple phone calls from a nurse care coordinator, or we'll arrange for lab visits every 3 months. And then, like I said, the patients at the bottom of the pyramid, because they're otherwise healthy, we assume they don't need much from us. And then When the patient at that top of the pyramid doesn't engage with us or doesn't return our calls, we call them non-compliant or not engaged in their care. And then when the patient at the bottom of the pyramid, because they were otherwise healthy and we assume they didn't need anything, if they're calling in multiple times because they want to visit or they have concerns and want to be seen, we call them an overutilizer, and then we throw up barriers to their access. It seems the answer would be that we should just ask patients. But we can't just ask them in focus groups or in surveys, because patients often don't know or can't verbalize what they really need or want. And this is often because of the barriers that patients aren't always obvious to them, and they're unable to be articulated well to their healthcare team. So I've included here, this is work that comes from the Patient Revolution, some Maggie and colleagues, and as you read through them, I'd like you all to take a moment here to reflect on your last clinic visit, or if you've been in the hospital recently, or had a family member, or have been a caregiver for someone, to reflect on what that experience was like for you and some of these barriers that may have existed for you or for a loved one. How can you help change the system? And how can we make a difference? Many of you are going to remember this slide from this morning, where Casey and I talked. I was aware that she was sharing it, and I wanted to share it here again, because I think it really illustrates well for all of us the work that's involved for our patients in order to manage their chronic conditions. If you take, for example, my patient Karen, remember I shared with you she was taking 2 diabetic medications. She had 2 medications for her high blood pressure, and then she had her cholesterol medication. So she was taking 5 medications already. And when she came in to see me for an acute flare of a chronic condition, I said to her, okay, well, let's manage this by having you take scheduled Tylenol and scheduled Aleve. To me, it seemed like a simple addition to her regimen, but that was because I lacked full understanding of the work that was involved for her in managing her chronic conditions. And these are just some of the steps that patients have to go through, in order to live with their chronic condition. This next is a picture of Maria Luisa, and some who have joined us before at an MDM workshop may remember her previously as well. And again, I wanted to share her because her, like so many of our patients, the work that's involved for them in managing their chronic condition can be overwhelming. For many patients, they will spend at least 2 hours a day managing their chronic condition. So if you think about it, in a given week, that's 14 hours. That's more than a 10 or 12-hour work shift that they're spending managing their chronic condition. If you think about Karen, when she wasn't meeting her goal A1C, my initial response to her care was that I ordered more follow-up tests, I ordered more appointments, and I intensified her medication regimen, all with the assumption that this was going to do something to change her diabetic care and to improve her outcomes. So it's not surprising that for patients with multiple chronic conditions, they will often experience more burden from their illness and treatment by having more tests, more visits, and more medications. Fascinating, though, is that in visits where workload discussions occurred for patients, for example, in primary care, that 70% of the time, the burden of treatment was left unaddressed. At least 70% of the time. And for example, with Karen and I had talked about later on about the barriers to managing her diabetes and the work that was involved. And she could recite to me quite eloquently everything she was supposed to do to manage her diabetes. She would tell me that she's supposed to watch carbs. She would tell me that she's supposed to watch the sugars in her diet, that she's supposed to exercise regularly. She would tell me everything that I wanted to hear, that she knew about her diabetes and she knew how to manage it. And the most surprising part, and some have heard me, I talked about Karen before, I know Casey's heard this, is the greatest surprise was one of the days that she recited to me all the things that she was supposed to be doing and she knew she needed to do. I saw sitting in her purse, because it was kind of sitting open, and it was sitting right next to her in the office visit, she had a bag of Fritos and a Mountain Dew sitting in her purse. So, again, we chuckle, but she'd said all that stuff to me, and I was thinking, wow, she really gets it, she understands it. And then I saw that sitting in her purse, and so I said, can you tell me about the bag of chips? And can you tell me about the soda? And when I asked her that, her answers, they opened my eyes. And what it started to get to was capacity, and that it was based on several factors. So for Karen, when I asked her, I said, tell me about that bag of chips, tell me about the soda, there was a couple things she told me. She said, well, I've been in visits all day, and I've been across this campus, and I work downtown here, so things are fairly close, but she didn't have transportation, and she said, I was running from one visit to the next, and she goes, I passed your vending machine on the way up. And she's right, our vending machine has chips, it has chocolate bars, or it has soda. So, I mean, that was her options for her to grab a meal at that point as she ran from one appointment to the next. And then when I talked to her, I said, okay, so let's talk about maybe can we prepare meals, before you come to work, or preparing meals before you come to visits. And based on the desire to really understand her and understand more, she finally shared with me, and again, we'd seen each other for years, and when I talked about trying to cook and prepare meals at home, she said, well, Summer, that'd be really nice if I could see my kitchen. I said, okay, I said, tell me more. She goes, I haven't seen my kitchen in 7 years. Her husband was a hoarder. She had one pathway that she walked into her house, to her bathroom, and to her bedroom. And that same pathway is the way she walked out of her house. So she didn't see her kitchen because it was filled with boxes and whatever else her husband had collected over the years. So for me to say, hey, go cook a meal, go prepare a meal, when she didn't, so she ate every meal out. So again, it was that assumption that I'd made that this was just an easy answer, an easy solution I could give her. So the other part is that she had shared with me that her daughter, who I had assumed was coming to visits with her for support and for transportation, was actually having her own visits and had her own chronic conditions she was having to manage. And then she also shared that her daughter had to move in with them along with her 9-year-old son. And that her 9-year-old son, which was Karen's grandson, had ADHD and had medications, things he needed to manage. So again, this home that's filled with boxes and filled with stuff now not only has 2 people living in it, but 4 people living in it. And Karen shared that day when we discussed again just what was going on with her life and her, that at her job, her employer had decided to let go of a lot of her colleagues. And so not only was she now doing her job, but she was doing the job of several of her colleagues who had been let go. So when it came to capacity for her, her bandwidth, her environment, her financial, her social support was all stretched. Which brings us back to the key of this conference, minimally disruptive healthcare. So how do we support patients in pursuing their goals? Do we need a new app? Do we need a new tool? Well, I'd caution us when we talk about tools, because we need to make technology work with us and not just create the services because the technology exists. And this is because technology changes human behavior and interaction, and often in ways that is very difficult to predict or control. Technology can automate many things for us, and it can make us more efficient, but it's also leading to a proliferation of communication modalities and is telling us more about ourselves and others than has ever been possible before. And it's doing so through documenting and recording things about us than we could have ever imagined. So I think what we really need to ask is, how do we conscientiously decide how we will use what technology affords us? How do we use technology to get to minimally disruptive healthcare? How do we humanize health and care and build relationships? How do we put patients at the center of everything we do and base it on their needs? The next few slides I'm going to show some of our shared decision-making tools. We'll look at the ICANN tool as it related to Karen, and then some prototypes that we've utilized in practice as we partnered with patients to understand what matters to them, to understand what risks, benefits, and trade-offs really look like for them in order to create plans with them and not create plans just for them. So in the example here, what we ask patients to do is we ask them to prioritize be more active, feel better, or live longer. And after doing that prioritization, we ask them to give us an explanation for that reason. And then the clinician would work with them to help shape that plan of care around that goal. And honestly, many times the decisions that we came to at the end of these discussions, they weren't always the ones based on the best available evidence. But for every patient who walked out of those visits, they knew what their diagnosis was, they knew the name of their medication, and they knew why they were taking it. example of the shared decision-making tool for diabetic medications. Again, this is designed similarly to the the depression cards that you all saw this morning. Again, the top portion discusses potential factors of importance for patients. And what this allows us to do is start with an understanding of what's best, and not what's best from the perspective of us as far as what the next medication is, what the next tablet would be on the best available evidence, or in order to achieve the next guideline or target, but really what's best based on what that patient values when they look at risks, benefits, and trade-offs. And it becomes a discussion between that clinician and that patient, that individual sitting in front of them, of what's most important and what they value. So with ICANN, again, you all got to experience ICANN, which again I think is the best way for all of you to get to experience it, and that ICANN really is trying to shift from a medical condition to a patient's life situation and try to identify what a person values and how to recognize the opportunities to help that person in their current situation. And when you start with the questions of what are you doing when you're not sitting here with me, or where do you find most joy, or what's on your mind today, it really changes the conversation. And I know Casey and I ran out of time, so and I know I don't want us to run short here either, but I want to share briefly, we had explored other questions, and fascinating was to ask patients the question of what is health? And it was fascinating when I would ask patients that, they'd say, tell my blood pressure under control, or have my A1C, and I'm like, okay, so that's what health means to me. I mean, that's what I've expected out of you for health. What does health mean to you? And I'd have to usually ask it a couple times or kind of probe to get patients to really tell me what health meant to them. Because otherwise they've been trained and experienced that health was really achieving their A1C goal or achieving their blood pressure under whatever set goal we've given them. So when Karen, when she had utilized this tool, again, on the side of areas of your life that are a source of satisfaction, burden, or both. Interestingly, for my work, she listed that as a satisfaction. And based on the history I shared, again, she was doing the work now of not only her work, but also her colleagues who had been laid off. I assumed that would have been a burden, but she found it as a satisfaction. Probably not as surprising as she said that eating well and being active were a burden. Then on the right side, though, when she was asked to put in what are the things that your doctor or clinic have asked you to do to care for your health, and are they a help, a burden, or both, she actually put that trying to be more active and eat better would be a help to her, and that what was a burden to her were all the tests, the appointments, and trying to organize her medications. So by having her complete this, it really helped her and I kind of guide and shape her conversation around, okay, so work is something she valued. Work is satisfying to her. So how do I make sure she doesn't miss time away from work? And what we discovered is actually her local pharmacy was willing to, because she had been spending her lunch hour break often refilling her medication, or she had her extensive big pill box and she would put all her pills in there to make sure they were organized and that she had everything set for her for the next day or for the week. And so she spent her whole lunch hour often doing that and managing that chronic condition, so it left her little time to do anything else. And her local pharmacy had been willing to pre-package her medications for her. So they're in little perforated packs that had the date and time that she needed to take them, and they also offered the service of either delivering it to her home, to her work. She could kind of pick what worked best for her. She could come and pick it up. By freeing her from that burden, that aspect of it, now her lunch hour was more open. And so she started to take a brisk walk during her lunch break. And after that became routine for her, she wanted to increase her activity, so she started taking the stairs. And as she will tell you, is that with that, she started to lose weight, and that it was without even trying. Again, I would argue that she was trying and she was doing stuff, but again, it didn't feel like work to her anymore because those were things that she was starting to enjoy, and she was getting to stay with work and do work, something that she valued. So I've really found that the ICANN discussion aid is a way to help facilitate that visit and facilitate that conversation and treatment plan for patients. But a word of caution. So shared decision-making or the use of tools that we've discussed are not a way to convince patients to do what you think or want them to do. They are not tools for coercion. I actually find this comment quite funny. So I'll give people a second to read it, but that is not what shared decision-making is for. So shared decision-making is really about a conversation between clinician and patient where they think, they talk, they feel through the situation. The evidence-based options are the hypotheses that are tested in the conversation until that best solution of the situation becomes clear. There we go, okay. And then some of you may remember this from last year as well, that shared decision-making is really about what is that situation that demands action, and what are the actions that the situation demands. This idea of a conversational dance. With these ideas in mind, we start to understand what it means to bring the voice of our patients and communities into everything we do. So in the last moments here, before I will take some questions here at the end, what I wanted to share with all of you is a project that myself and I really would like to bring her up here, but I won't put her on the spot and make her do that because she already helped me with the slides. But Maggie Breslin, that some of you got to in the breakout session work with, so from Patient Revolution, her and I have gotten to partner on this work. And honestly could not be done without her. But it's called a patient voice work, or what we've termed in. It's been a community and clinic partnership with our Austin and Albert Lee community. So the background for everybody is there was a grant that Mayo received funding, the Transforming Clinical Practice grant through CMS. And a component of it was to incorporate the voice of patients into the work that we were doing. And when they first approached us and said, gosh, we really want to bring the voice of the patients into the work we're doing, I said, okay, so we started to kind of think about that. I had the opportunity to chat with Maggie about it, and then we came back to the group, and they said, well, one of the areas we really need to focus on is in this community around ED overutilization. Patients are just using the ED way too much, and we need to decrease that, or we need to increase the access in primary care. So what we said is, okay, we understand that that's the problem as you see it. You see it as ED overutilization or a lack of access in primary care. We asked to give it a different approach. And our approach really started with an ability to talk with patients, with the community, with the clinic and the employees, and to seek to understand. Fascinating was what we found from these findings. So from the clinic's perspective, when you talked about, ED overutilization or the access to primary care, the assumption was we just needed to educate patients better about the services that were available to them. And the clinic would share that there was financial and operational constraints that really to increasing staff and resources. So that was a barrier to them to change this idea of increasing primary care access. From the patient perspective, they said, gosh, the clinic really just needs to make it easier for us to be seen. I mean, we had patients who described primary care in these clinic locations as Fort Knox. That if they called to get in, I mean, there was a lot they had to do in order to jump over all these hoops to be seen. And because of this, for the patients, what we termed it as, we said, a lack of perceived agency. Patients really felt like they lacked control over this idea of access. And so with that, they had a limited sense of responsibility. So it became, the clinic said, it's the patient's problem, and the patient said, it's the clinic problem. So they were all pointing fingers at each other. What we proposed is to say, let's think about access as a community resource, where both sides have a responsibility to address it. So it's not just the clinic's problem, it's not just the patient's problem, but let's look at this from the community perspective, where both sides have values and the voices must be included. So with our approach, we have it rooted in relationships and stories. We listen to the stories, we hear from the patients, from the clinic, from the community. Reach out to populations that often otherwise would not have their voices heard. So these were not necessarily through patient and family advisory councils or through focus groups. This was, and again, where I want to give tremendous kudos to Maggie and all the work she's done, because again, she was boots on the ground, meeting in wherever people were willing to speak with her and chat with her to really get that background and information. And it allows for this bringing together, which builds trust, and it has benefits from facilitation, which again, that role from the Patient Revolution, so the conversations can address the areas of conflict in more productive ways. So people feel less adversarial, so they start to see things from a different perspective. And the relationship then allows for this partnership to overcome the conflicts and barriers that usually, where people would say, there's just nothing we can do, and they just kind of toss their hands up and give up. We also challenge assumptions. So we are not constrained by current thinking, perceived solutions, or expected outcomes. We try to understand the data in relationship to the human experience, and we are creative in thinking about new possibilities and ideas. So you heard me say that the clinic said, well, we just need to educate patients better. One of the workshops or kind of research things that we did was a community event where we sat with community members and said, tell us, what's the ED for? Tell us what urgent care is for, what express care, what primary care is for. They could tell us. I mean, the patients would say, if I was in a car accident, I'd go to the ER. If my arm had fallen off, I'd go to the ER. If I have crushing chest pain and I think I have an active heart attack, I go to the ER. And so then Maggie would very astutely again, because I just sat and kind of observed the whole thing. Maggie goes, so when was the last time you used the ED? And the patient goes, oh, I just used it on Friday. And we said, okay, well, tell us more about it. Why did you use it on Friday? Well, my child, I thought, had an ear infection, and I called primary care, and they said, well, we can see you next week. And they were headed out of town, so they went to the ER in order to get their concern addressed. And then this question and the creative thinking part is, one of the things we proposed was this idea of how might we carefully and kindly turn people away from the ED. Again, nobody lose or have a heart attack. I know that you cannot actually turn people away from the ED, especially as they cross the threshold and they're in the ED. But again, we wanted to really explore understanding what was bringing people to the ED, and again, it was an idea and experiment where we said if we were situated outside of the ED to understand for patients what was bringing them there, could we look at ways to carefully and kindly suggest or bring them other options. So again, we did not turn anybody away from the ED. Nobody did get nervous about that. But it's that kind of creative thinking and challenging assumptions that's allowed us to really move with this work. And then the last part is that we build to learn. So the hypotheses are actually tried out in real-world settings. We don't have the experiments all figured out. We don't have the solutions figured out. And the experiments are actually forthcoming. It's work that Maggie's here for right now, and in the coming weeks and months, her and I will be out there in the clinics and communities working with the clinic, with their population of patients, and saying, okay, what are some of the barriers, what are some of the challenges you guys have experienced, and how do we look at trying to have some solutions and experiment around it. And that the experiments are to help us understand what a benefit would have and allow us to understand what tools and support might be needed in order to undertake a new behavior within that clinic or within the patient. And they're rarely going to be, and I think this is the hard part for those who ever tried to experiment and do stuff, is that this is not piloting. This is not where we have a solution and we're coming in and saying, here, try this shiny new thing and we're just going to implement it and it goes everywhere. We don't have the answers all yet. We've done a lot of research. We have a lot of themes that have emerged, and we're going to challenge and explore and experiment with those within the clinic, within the population and patients. So there will be more to come as we conclude those experiments here through the end of this year. And happy to, in future, if it's of interest to people, or to share that stuff in the future, because again, our hope is to share this work ongoing for other communities and for other people. So that is it. I know I left only 5 minutes for questions, but I'd like to ask if anybody has questions.
There's more work to come. That means I get to make Summer do this again next year. She's already invited herself.
Awesome. Thank you. I missed that caveat. No, any questions? Yeah.
What is it when it's an experiment versus a pilot? What is staff response or clinician response in terms of your implementing an experiment? Are they frustrated that it's only an experiment? Are they happy to participate in something that's new and unique? Kind of, what do you get back from them when you're trying that out?
So very good question, and Maggie, you get to jump in if anything I say is incorrect. So again, the experiments that I have had an opportunity to participate as the clinician in it, but also helping lead my other clinician colleagues. I think one of the greatest areas I've discovered at first sometimes too is really separating for people that it's not a pilot. So often for clinicians, your people, things have come in, and again, that's why I had that comic strip of, hey, here, tell us about this, but it's already going to happen, the decision's already made. So then they're really frustrated by that. That's the other part of this partnership stuff, is we're not coming in saying we have all the experiments figured out. What we're actually coming in and the meetings that we have end of this week and next week with both of the primary care teams that we're going to partner with is to say, here are some themes that have emerged through conversations with you, with your patients, and with your community. Tell us about it. Let's explore how do we address some of these themes that have popped up, or what are things that you guys have noticed in clinic. So we're going to have them partner with us to help us create the experiments. So we don't have them all fleshed out. That's why I can't show you up here and say, here's what they're all going to look like right now, because we haven't decided it. So I think that that's what helps people engage in it, is because there's not a decision already made, and we're not just telling them, hey, buy in. So, yeah. Go ahead.
As to ICANN,
Yeah.
does that stand for something, and is it proprietary, and is it available
I can answer that.
I can.
So I can.
Pun intended, yeah.
Pun intended. That name came about. It did stand for something. It stood for something prior to its creation because we had to have something to submit the grant. And somehow that name has lived on. So originally it stood for the Instrument for Patient Capacity Assessment. We have since dropped that because it doesn't actually assess anything. We don't think it's an assessment tool. It's a conversation aid. So then we called it the ICANN discussion aid. And the reason that has lived on is that oftentimes people that use it say that that's so fitting because it really does empower the two people who are having the conversation to say, I can have this conversation. I can talk about these things. It gives them permission. So in some ways it's still fitting, and we just call it the ICANN discussion aid. The front of it looks like My Life, My Healthcare, but in the papers that it originated from were all ICANN discussion aids. It's not proprietary. It's free to use. The version that Summer showed is actually the version that's on the website. The version that we used in this breakout session, you can email me if you want that version. That will be released as soon as our current ongoing trial using the old version is complete. And that'll be freely available to the public. But if you want to use the newer version earlier, you can contact us. We can ship you some, or you can get the PDF, whatever. It's not proprietary. There's no money being generated by using it.
Donations are welcome, though.
Huh?
Donations
Yeah, donations are welcome.
Well, in what case,
Like, we gotta keep the research going somehow.
what Casey didn't share is ICANN and others. Those are also brainchild acronyms that come up from the care unit group. Like one of my grants was named ICE-T. So when you can't come up with things, the team in there in the group really come up with fascinating things. So
We're great at naming things. If you have anything you want to throw out.
Other questions from the group?
Sorry.
Yeah.
You have not told us some of the themes that have come out. Perhaps maybe mention one or two that were particularly surprising or unexpected. The things that, if you had thought about process of access or ED, I think the group could probably come up with 25 reasons why that might happen just from their imagination, but was there something surprising?
So one of the concepts that we've shared with people is around this idea of emotional and clinical need that patients are looking to obtain when they seek medical care. And when we talk about emotional and clinical need, it's often what patients are really seeking from primary care. They're hoping that their primary care team or clinician can address that emotional and clinical need, but that they're willing to forego that emotional need when they need the clinical need addressed. And what I mean by that is that, so again, that example of the patient who said, well, I know what the ED is for, but they needed to make sure their kid didn't have an ear infection before they left town. They will, even if they have to wait in the ED for several hours, they know when they go to the ED that they're going to get whatever tests they need, they're going to likely get a diagnosis, and they're going to get treatment before they leave there. When they call primary care, often they're sometimes told, well, we can't see you for a few more weeks, or depending on what chief complaint or what diagnosis they give, they're told that they can't be seen for 3 months. So then they'll often seek others. So that's one that stands out to me. Trying to think of other key one, Maggie, that you can think of off the top of your head that stands out. It's okay. Well, the other one that came to mind too was this idea of access. We talk about access, and that, again, where I shared where the group can say what the ED is for, what urgent care is for, what express care for, and what primary care is for. What patients don't recognize is how they're all connected. They all feel like, and patients perceive them as silos or as places where they're pushed off to. When we're in the community group, when we talk with patients, and you would mention, ask what's express care, urgent care, they're like, oh yeah, primary care didn't want to see me, so they told me to go to express care. Or urgent care, well, I went there because I was going to show up at the ED, but then that's probably going to be more expensive, so they told me I should maybe be seen in urgent care if I wanted to. So they don't feel them as extensions of primary care or all as parts of the whole, something that all of Mayo Clinic is offering to them, but rather, depending on what I need and if primary care can see me or not, I might get told to go to these other places. So those are two things that really stand out for me, and that the last one I'll share too is around access, that access is not just about slots. So example I've often given when Maggie and I have been talking to groups about this, because we will hear repeatedly from people, we just need to increase access. We just need to put more appointment slots for patients to be seen, and that will solve everything. It's not the field of dreams. If you build it, they're not necessarily going to come. Their patients don't have that trusting or built-in relationship with their primary care, particularly in this community, that you would need in order to be able to have them utilize primary care in the way that would be intended.